Hello, hello, hello. And today on the Smooth Brain Society, we're joined by Zoe Swithenbank, a senior research associate in health research at Lancaster University. Zoe works at the intersection of mental health, addiction, and public health, looking closely at how people with complex needs navigate care and how services can better support them. Her research spans treatment pathways for people with both alcohol use and mental health challenges, the realities of supporting behaviour change like smoking cessation, and the structural barriers that shape access to care. Before academia, she worked directly in mental health, addiction, and homelessness settings, experiences that deeply informs her research perspective. Beyond the research, Zoe contributes to the Addiction Audio podcast and volunteers with a national mental health charity, helping bridge conversations between lived experiences, frontline practices, and evidence. Today, we'll talk about her journey, her approach to qualitative insight, and what meaningful change could look like in mental health and addiction care. Welcome, Zoe. Well, thanks very much for joining.
Thanks
So,
for having
question
me.
we always no, yeah, great to have you. So, question we always start off with is almost what is your origin story? What got you to the place where you are today, and the research you do, and all the PPI?
So I ended up in research because I initially ended up in addiction treatment myself and in mental health treatment about 10 years ago now, I think just over, and got very involved in kind of that world, the sort of recovery focused stuff. So I ended up volunteering in both services and then working in substance use services, and I wanted to do more. I felt like obviously I felt like I was helping people kind of on the ground, but I had a lot of kind of questions around sort of the policy side and the organisational aspects. So I found a master's that was close enough to me to commute, which was in public health with an addictions focus. So I did that, loved it, and that kind of everything went on from there basically. So that was the sort of foundation for my PhD. I built on that, and yeah, that's why for me lived experience is really important.
No, awesome. So then you said PhD. What was sort of your PhD in? Did it link? Does it link quite well to sort of your experiences, or was it like how some of us do PhDs, which is we decide that okay, this is the best sort of idea we can find because somebody else is doing it and jumping on board?
I was really lucky. So the Society for the Study of Addiction funded my PhD. So it was, yeah, so I wrote it. I wrote the proposal and everything, and it was based on my experiences in treatment. So for my master's, I interviewed people in residential treatment about their sort of attitudes and perceptions around smoking, and if that was a helpful sort of context to be looking at it in, and got some really interesting stuff. So for the PhD, I wanted to kind of build on that. So yeah, it was very much kind of built around what I knew from being in and working in services, and what I'd seen, people I'd spoken to, and then on that research, I wanted to do more and figure out not just is this a good idea, but what does it look like? How can we do it?
Yeah, interesting. What kind of services were you looking at for in relation to the addiction?
So I interviewed people from across the northwest, for people accessing substance use treatment services. So they were for any substance, and the kind of general eligibility criteria, if you like. If someone thinks they've got a problem with a substance, then that's good enough for me. Don't rely too heavily on sort of official diagnostics, because that misses a lot of people. So yeah, it was anyone that was accessing either community or residential services, to address their substance use.
I think we should probably ask a slightly basic question, which is what do these sort of services look like, or what help can you receive for somebody who has sort of no idea about them, no idea about these organizations, what they do? Could you sort of paint a picture for us?
Yeah, so starting with community. So if one of us decided that we thought we could do with some help, you might go to your GP or you might Google and find your local service, and you'd either get an appointment or you'd turn up and speak to somebody, and say, I'm concerned about my alcohol use or my drug use or whatever. And you'd meet with a key worker who would do some kind of assessment, so fill in all the paperwork as to kind of how severe that is, if you like, and what's going on for you, and sort of all the other issues going on. Because it's rare that these issues happen kind of in isolation. There's normally a whole host of things going on, which is why I'm also interested in the mental health aspect. So you do that, and then once you've been accepted into treatment, then the pathway will vary somewhat depending on your personal situation and the substance. But generally, you'd go through a series of kind of group work programs where they'd work through sort of starting from, motivation to change, learning about recovery and what that looks like. Obviously, if someone's physically dependent, then there will be sort of that aspect of it too. So whether that's medication or some kind of detox. So there's different options and different sort of pathways depending on the severity and all the other issues going on. But the group work is a big part of it, and that's kind of why I was quite keen to do something looking at that, because in my experience there was a lot of focus around recovery, which is great, and I think that's really important, but the services kind of have limited capacity to actually work with that. So again, I'm backtracking, but for me, recovery is not just about not using the substance. It's a really holistic process about improving your life. So that's why for me, smoking cessation is a really important part of it. So physical and mental health. It's not just about I'm not using drugs, so I'm okay. But what else? How is your life? Are you happy? Are you fulfilled? Does your life have meaning? So it's all that kind of stuff that I think is a much bigger part. But due to the way that services are funded, there's not always a lot of kind of follow-on support. So once you've kind of hopefully successfully completed the treatment program, there might be some kind of recovery support you can access, but it's generally a lot less structured, less available, because it's not part of the sort of core treatment offer.
That makes sense. So when you say about groups, is it things like AA, or is it different types of groups? We've got one in the North East called Recovery Connections, for example. Is it the fact that you're kind of building like a life around that, instead of it just as soon as you stop taking, whatever substance you're taking, there's so much more than that. So you're building a life afterwards, I guess, isn't it?
Yeah, definitely. I mean, for me, it's kind of a combination of the statutory services. So they're normally run by, well, occasionally NHS, but your CGL, your Turning Point, your Westminster Drug Project, and others. And they'll do the more kind of structured groups, if you like. But then so some people use AA, NA, Smart Recovery, or other sort of independent groups, either as well as or instead of, depending on people's need, treatment. So yeah, it can be quite varied, but so the group thing is quite common across the whole spectrum of treatment for various reasons. But yes, for me, it's a lot about that building kind of community and social capital, and recovery capital, and yeah, that's a big part of it.
Yeah. And so with your work within smoking cessation, are you trying to add in, like, as well as, like, okay, you've stopped your substance. I don't know if smoking classes as substance use, or I'm not quite sure. I guess it's a middle ground, that one maybe. Is it, because I guess like smoking, of course, we know doesn't help you. So I guess it's trying to the next level of after you've maybe stopped maybe the whatever substance you've been taking. Is it the fact then you're stopping the smoking because that is just not going to have in the long term good health benefits, for example?
Yeah, I mean, I think that's a really important point, because one of the things that keeps coming up when I talk to people is it's about the timing. So some people want to do everything at once. They want to stop using drugs, alcohol, quit smoking, join the gym, do all these other things. And for some people, that's great. For some people, they want to do it one thing at a time. So the key point for me is about giving people that choice to do it when they feel ready to do it. And I say that is an issue, that sort of the really long-term support isn't there, certainly in the statutory services. So it can be a bit like, great, I'm ready to quit smoking, but now there's no support.
So, I mean, you've actually nicely come on to our next question I was going to ask is, you've kind of briefly touched on it, but what do you think are some of the barriers or gaps you're seeing in the way care is currently structured for people with these like co-occurring problems, like smoking, for example?
I think one of the issues is that it's about the funding and the commissioning of services. Generally speaking, drug and alcohol treatment is funded to deliver substance use support, and that usually doesn't include smoking. So it's kind of a nice add-on, and there are people that are kind of trying to build that in, but it's not really a core funded part of the service. So that in itself is a bit of a challenge. I've spoken to a lot of people who work in services, and there's mixed views generally. Some people think it's really important and definitely something we should be addressing, and they would like to do that. But generally capacity is so limited, particularly kind of post-COVID. A lot of people were really enthusiastic, but said, but please don't make me do it. I don't have time. I can't fit it in, already overworked. So that's a big one. But then some of the staff didn't think it was that important, or it wasn't their job. So for me, that's kind of, we need to look at why that's happening and encouraging staff to feel able to offer that kind of support and willing to do so.
Do you think it's also like smoking itself has sort of a different, or has a wider acceptance in terms of like normal society, that it's not considered as much of a problem? Is that one of the reasons why there's not as much push to it as well?
I think that the legal aspect is a huge issue, which is interesting when you look at alcohol. It's generally seen as a lot more socially acceptable, and particularly within people who use drugs and alcohol. I think the current UK prevalence or England is around 10%, whereas the data released this week reckons that it was, I think, 44% of people accessing treatment, and I'd argue that's probably an underestimate. So there's this massive gap between what's happening between the kind of wider population. But I think part of it is it's so kind of socially acceptable and culturally kind of ingrained within people who use drugs and alcohol. So if you go to something like an AA meeting or a SMART meeting or whatever, a lot of them will have a lot of people who smoking breaks will be kind of built into some of the program, like, the convenient break points instead of coffee. It can be a really useful tool as well for like building that therapeutic alliance. That was one of the things that I found when I was working in services. We were almost encouraged to kind of bond with people. You go outside after a difficult group and you have a chat, and that would be usually over a cigarette. So yeah, there's a whole kind of host of issues that make it particularly challenging, I think, to address, and one of that is kind of that socially acceptable aspect of it.
Yeah, I guess if it was the choice between going back to the substance, like the addiction, is it better for that or to have the smoking addiction, is probably what I'm kind of getting is the feeling of what you're saying.
There's a lot of that, yeah, and there's a lot of concern. I think that people are like, I'm focusing on the thing that's going to immediately kill or harm me. So the smoking, I can worry about that later. But I mean, there is evidence that if people can address both at the same time, the outcomes for both are improved. So that's not generally kind of acknowledged. I don't think it's very much a one thing at a time. You can't do everything at once. So don't kind of stress yourself. And it is a really stressful situation. When I spoke to people in rehab, people are away from home. They're dealing with a lot of stuff. And for someone to then say, while you're in that really vulnerable place, great, now you can quit smoking. Not always the best way to do it. I mean, I spoke to people that started smoking in rehab or in treatment or went back to smoking because there's a whole host of reasons, but, what do you do? People are anxious, people are bored, and it just becomes a big sort of part of their life again.
So within this, what were the key insights about how service support people who want to change health behaviours? Were there any key findings within the research that you were doing?
So I was looking specifically at behavioural interventions. I mean, we know that there's plenty of pharmacological stuff that works. So that did come up a little bit, but I was looking more at things like, mainly at the acceptability to people accessing services. That was kind of what I think makes my research quite unusual, in that it wasn't looking so much at effectiveness, because we know what works. There's decades of evidence on smoking cessation, but it's what works in this context, and how can we get that? How do we get people to actually access it? If people access the stuff, then it is effective, but there's so many barriers in place that can be really difficult. So yeah, for me, it was going through every recommendation, every suggestion of what would work, and kind of applying that. If you're familiar with behaviour change, the behaviour change wheel, then I use the APPEASE framework. So but with a bit of a twist. So one of the letters is acceptability. So I made that kind of my, if you don't meet this, you're not in kind of thing. But it was acceptability to people who would be accessing the service. So obviously it needs to be acceptable to everyone. We need organisations and management and staff to be on board. But if people accessing it aren't going to like it, aren't going to think it's worth doing, then I don't think it's worth doing. So that was kind of how I sort of filtered and focused my recommendations about what we should be doing. I mean, in terms of what the recommendations are, there's a whole host of them, but there was kind of broken into 3 sections, if you like. So the first one was kind of the underpinning ethos, which for me is really important, and that's kind of should be underpinning everything and influencing how these things happen. So there's issues around, excuse me 1 second. Choice. I think I've mentioned that was really important and how that relates to recovery. So it's empowering people to make those choices and to do what works for them when it works for them. Linked to that, there's the concept of agency and autonomy, because a lot of people feel like that's kind of taken away. You get what treatment you get. You don't always get a huge amount of choice in how that happens, and people can feel like they don't have a lot of control. So giving people that back is really important. And then around the availability and accessibility of whatever service that may be. So we need to be looking at things like where it's offered, who it's offered by, what time, because a lot of the services, unfortunately, are Monday to Friday, 9 to 5. And that doesn't work for people for a whole host of reasons. So we need to make things not just acceptable, but accessible. I can tell you what the specific recommendations are for what a smoking cessation intervention should look like, but they're the kind of broad things that I think apply to any sort of behaviour change in this context.
I'm just interested a little bit in how these recommendations sort of came about. So who all did you speak to? Did you see sort of buy-in from both service users as well as service providers? Sort of a little bit about the background to how we got here.
So I did, for the PhD, it was 3 studies all looking at a different source of evidence. So I was really interested in this idea of what are we using as evidence? What are we calling kind of high standard evidence? So I looked at an existing systematic review that I'd worked on previously and looked at what behaviour change techniques people were receiving as part of a smoking cessation intervention, and compared that between kind of the general population and people specifically targeted interventions for people who use drugs or alcohol. So I wanted to see, are they getting the same thing? Are they getting effective things? How does that work? So that was kind of one. And then on a similar, not the same project, but another aspect of it that I'd worked on was a consensus meeting, so part of a modified Delphi study, where we got a load of experts in smoking cessation research together and kind of had a very long, in-depth discussion about what they thought reporting guidelines should look like, but that kind of in itself defines what the intervention looks like. So that was kind of all the sort of background stuff. And then the really kind of key bit for me was then the interviews with staff and people accessing services to get both of those perspectives. Because I think I said, you need both. You can't, if one side isn't on board, there's no point doing it. So there were definitely differences of opinion amongst and between the different groups. One that for me was really interesting is that nearly every person accessing services that I spoke to said that they thought the staff working in the substance use service would be ideally placed to offer this. They said they already know about addiction, they already know about these things, we've got a great relationship, they would be brilliant. Nearly all of the staff said, I couldn't do it, I don't know enough, or I don't have capacity, I don't have the skills. So there was definite sort of difference in perspective about who was qualified to offer that, really, which I thought was really interesting, that the service users had much more sort of confidence in the staff than they had in themselves.
It sounds like empowering the staff would be a really good step from what you're saying.
Yeah, definitely. That's one of my kind of key recommendations for future work, is we need that. Because it is difficult, particularly when you're talking about things like e-cigarettes, which come up quite a lot. I've spoken to health professionals and a whole range of people who just aren't entirely sure what they're supposed to be saying about e-cigarettes, because it is so fast-paced. Evidence is constantly changing, and recommendations are changing from NICE and people. So it is really difficult for people to feel like they have a definitive idea about what they're supposed to say and what they're supposed to recommend. So I think that aspect for me is something that definitely needs some further work.
It makes sense. Is there an area or a group which you've done interviews of that you feel have already set up quite a good kind of almost like protocol or kind of setting that kind of is something that you'd like to mimic elsewhere, or is there nowhere that you think is doing a particularly
I'm very interested in some work that's happening. I think CGL are doing it down in Croydon. So this is not part of my PhD. This is just some work that I know of. So
please
check the details with them, basically. But because they're looking at not just smoking cessation, but kind of a harm reduction and a sort of motivational aspect to the pathway. So it's not just a lot of smoking cessation interventions for any population are based on you set a quit date and you do, whether it's behavioural support or your nicotine patches or an e-cigarette, and then you quit smoking. And there's not a lot of wiggle room in that. Doesn't always work for a lot of people. I think the idea is that you've had one cigarette, therefore you failed. That for me was a massive problem, because if we're just setting people up to fail, and then all the things that go along with that, feeling like you've let yourself down or other people down, can lead to a bigger relapse, if you like. So I think that's really important, looking at those different approaches and how can we reduce harm and encourage people to kind of want to make those changes and feel ready to. So yeah, I'm very interested in the work that they're doing, because they're using those kind of different pathways to sort of encourage people rather than just a straightforward, you must quit smoking now.
I guess so. From what I know, please tell me if I'm wrong here. Just with with substance use and addiction, when people go to rehab, a lot of the time what they do is they give everyone the tools. So if they do fall off the wagon, for example, I've heard people say is they like, it's, that's not failure. It's you being able to have the tools to be able to be like, right, this is not the end of the world. I can become sober, quit this addiction. Or I guess, so would you say like smoking, you would do something similar where it's like, even if you have one, it's like, that's not a failure. I've got the tools to kind of help me carry, stop smoking again, less.
I think that's a really important point for smoking and for all substance use, that we can get into this mindset that you've had one drink or one cigarette or whatever, and you failed, and that can kind of spiral into a self-blame and all the rest of it. So it's kind of switching that onto, okay, this happened, what can I learn from it? And it doesn't undo all the work you've done before that. If you've been sober or quit smoking or whatever for so long, having one does not take you back to square one or even further back. It takes you to, well, I'm at this point, what do I know about it? What can I learn from it's that whole thing about a lapse versus a relapse. A lapse is not, you start from scratch again. It happened, but I have the tools, I have this information, and I have now this experience to add to that. So what can I learn from it, and how can I move forward? And I think that's a really positive thing that we should be encouraging.
The other thing, I guess, which is hard, like you mentioned, is a lot of programs like SMART sort of have smoking breaks almost. You didn't say the word encouraging, but it is in a way like saying that it's okay to do this, okay to smoke. Does that mean that we need to sort of change our approach and systems to account for smoking now? And then how would you replace what people have accounted for as like, yeah, smoking is okay, to change that? Am I making sense with what I'm asking?
I think so. If my answer's completely off target, then we'll revisit it. But it's very much a social norms kind of issue that needs to be shifted, and a lot of that is around people's attitudes with the whole, one thing at a time. You can't do that, and a lot of people you talk to will say, "Oh, I've given up everything else. I can't give up this. It's my only vice. It's all I've got left," kind of thing. So it's sort of about shifting those the social norms to making that okay. But not working the sort of general population. We've changed so much in how we view smoking over the past couple of decades. It used to be you could smoke everywhere. You could smoke at university. You could smoke on a plane, and now that seems ridiculous. You wouldn't think to walk into work and light up, would you? But so it's kind of shifting that in a way that doesn't feel like it's being what's the word? You want people to feel encouraged, not punished. I think that's one of the issues that people feel like it's a lot around identity, particularly if you're in recovery or accessing treatment. And people can kind of struggle with that, and figuring out your identity as now a non-smoker can be quite difficult, particularly if your identity is now become part of this group of people in recovery or trying to be in recovery, and they all smoke. So it can kind of be quite challenging on an individual level. So I think by trying to challenge some of those social norms and saying, we know smoking happens, but we're not going to make it easy, if you like. So yes, you can smoke, but you have to go, off the premises or whatever, where making it just that little bit more of a choice, I suppose, to do it rather than just the default. I think that's kind of the big issue for me. And I've forgotten the rest of your question. I'm sorry.
I mean, no, that kind of answers it quite well. In sort of like, yeah, encouraging it, sort of making it like it is a bit more of a choice for you to actively do it. Um, no, yeah, thanks. I'm still thinking of like in the 60s how smoking was allowed on planes. Blows my mind. Like, surely that's not a smart idea in any way.
You wouldn't think so, but yeah.
No. So I know we've spoken a little bit about the smoking cessation and the addiction, but we also a little bit. I want to chat a little bit about the mental health and addiction as well, because I appreciate you volunteer for a mental health charity. So, what do you think? In what ways, like health systems, maybe do they separate mental health and addiction too much? Do they kind of go hand in hand with each other? Does it truly reflect like this lived experience? I think there's a bit of a mismatch in there, basically, and how they kind of like the comorbidity, shall we say?
I think there's very much a mismatch with kind of what people are living and what services are kind of acknowledging. So, like I said, substance use services are commissioned and run by non-NHS services usually, whereas mental health is usually NHS. So you've got a whole host of issues there that the separate services, separate organisations, separate IT systems, separate staff, separate everything. So getting those two to communicate can be quite tricky if you even get into one. But there's also this issue of kind of access, that if you turn up to a mental health service and you have a problem with alcohol or drugs, quite often they'll send you away. You need to deal with that first. We can't talk to you while you're intoxicated and all that sort of stuff, which can be really difficult because the two go hand in hand. For a lot of people, substance use is how they cope with their mental health. It's how they manage. It's self-medicating. Not for everyone, obviously, but for a lot of people. So being told that you have to stop so we can deal with your mental health can be really damaging, because if you stop, often without support, you're left to sort of sit with the reasons you were drinking or taking drugs in the first place. So it's not a very, I don't think it's a very person-centered approach. And it feels like a bit of a ping pong effect where you can be kind of bounced between the services depending on your eligibility and who you speak to. And yeah, I mean, we've done some work at Lancaster looking at the treatment pathways for people with co-occurring substance use and mental health conditions. And we've got an amazing lived experience group that we've worked with over the last couple of years. And some of their stories will totally reflect that the pathways are not easy, they're not straightforward, they can be really complicated and kind of leave people feeling quite frustrated, and that they don't have, basically unempowered, whatever the word for that is.
How it's good.
So wait, did you say that the NHS doesn't necessarily cover addictions as much as it does like sort of mental health?
Yeah, the addiction services are usually tendered out to different organisations. They come through the public health grant rather than through the NHS. So it's a whole different funding system, and also with things like with the substance use services, they normally go up for tender every few years. So you've got that additional fact that you might have a great relationship with your key worker or whoever, and then the service gets recommissioned and someone else puts a better offer in. So you suddenly have to go back and start from scratch with some. Not always the staff will stay on depending on the situation, but it can add an extra sort of layer of disruption to that. And yeah, it's because they're not part of the NHS, so they've obviously worked really closely with them. So that could just add a whole load of extra issues in communication.
Then you're sort of losing that consistency, right? If something changes, then suppose like a session happens on a Wednesday, it doesn't happen anymore. And if you're not given the right information.
Yeah, that's a massive issue. And when I was working in services, I think I was volunteering when we had a sort of shift from one organisation, one provider to another. And that was very difficult for people, well, for the staff, obviously, because they don't know what's happening with their jobs. But when people who are accessing services have had a routine for the past however many years that this is what they do, and then suddenly you come and the door is shut that day, that for a lot of people can be really, really damaging. You've got your routine, you know that keeps you safe, that keeps you well, this is what you do, and then you feel like your kind of support network, your lifeline's been taken away. And yeah, having spoken to some people who kind of lived through that, for some people it was really, really damaging.
It's so sad to hear that when people, even if they are going through addiction, going like, I need some help with my mental health, like can't do anything. That sounds like a huge, huge problem. Or even being like we can give you this level of support, and we can put something in place when you stop drinking, almost like when this happens, you will go straight. We can, support as much as possible. I guess how do you think they would be? How do you think you could integrate the two? Because as you said, addiction and mental health go hand in hand. How do you think, in an ideal world, how would they? How would you integrate them? To be dealing with both alcohol and mental health issues.
I think in an ideal world, it would be one service that can deal with everything. So you've got, I'm not saying everyone has to be an expert in everything, but having staff who are an expert in mental health, who are an expert in substance use, and having that kind of very holistic approach, and not, so that would get rid of, in an ideal world, obviously, some of the barriers between people having to, to physically move between services, but also of kind of how that information moves between services. Because if you go and you're trying to get support, you don't really have to kind of, you're spilling your guts on, this is my life and this is where I'm at. And it's really difficult. And then you have to go and do the same thing again in a different service. So that kind of not having to constantly repeat, and kind of go through that trauma again in itself is really powerful. And then having other people sort of around instead of just relying on that one service that doesn't always have the skills or the expertise be able to deal with multiple issues because they are so intertwined. I think for a lot of people it is really difficult to deal with one issue at a time because there's just so much, they're so interconnected, it's really difficult.
Yeah, so integrating this, that makes complete sense. So from hearing you mainly use, I assume, qualitative research methods, so that's not, for people who maybe are new to qualitative, quantitative. Quantitative is mainly it's numbers and single word kind of things that you can kind of put in boxes. Qualitative is conversations. As an example, I'm sure there's a whole host. You can tell I'm a quantitative researcher rather than a qualitative here. So, can you explain why those may be especially useful for understanding addiction and mental health experiences?
I think for me, the qualitative, that's kind of why I got into this, because I wanted to kind of showcase those experiences. Showcase isn't quite the word, but give people a voice, because all the treatment and research to some extent can be, I'm going to use disempowering again, unempowering. It's really difficult to kind of feel like you have control, autonomy in that setting. And I think as researchers, we can sometimes unintentionally reinforce that. So I think actually listening to people, giving them a voice, asking them what their experiences are and what they think is important is not just good for them, but it's good for the research. If we don't know what's going on, we can come up with abstract ideas about what we want to know that can have very little relevance to what's happening on the ground. So I think for me, it's really important to talk to people. This is why I'm a big fan of PPI and lived experience involvement as well as qualitative research, because you get that kind of additional layer, if you like, of that input. But yeah, I'm technically a mixed methods researcher, mainly because I think there is often a disconnect between the quals and the quants people. So for me, some of that is trying to kind of use both of them to kind of make a stronger argument. Because if you're not convincing people by, that it's a good thing to do because it's ethically a good idea, you can often convince them that it's financially a good idea. So I think the more kind of tools you have to do that, the better.
A good example would be with maybe while qualitative is better than quantitative is how are you feeling today? 2 boxes, good, bad, and it's I'm sad, I'm angry, I'm frustrated. There's so many different levels of bad and so many different levels of good, and then there's So it absolutely makes sense, and
as a qualitative researcher, so how hard is it to sort of synthesize different opinions? I guarantee you, or I can assume that the number of people you spoke to, even among service users, would all have had different opinions about what to do and how to do things. So how hard is that?
I think for me that's one of the challenges, because you want to make sure that everyone's voice is heard because they're all equally important. Which is why in some of my findings I've got sort of what might seem like slightly random, obviously not technically random, I'm not a quants researcher, suggestions. So someone was really keen on acupuncture, for example. And that was, one person brought it up, so I feel like it's valid, but I can't say that there's a consensus because no one else mentioned it. So it's difficult to kind of make sure everyone's voice is being heard without it getting lost in that kind of trying to generalize too much. but then you sort of need to make recommendations. You can't say one person wants this, therefore that's what we're doing. It needs to be, sort of a bit stronger than that. So it is really difficult, and there's so many different perspectives. And if you start doing something like a focus group or something, then you're going to get all those different people sort of talking, and arguing potentially, and all the rest of it, which is what makes it really interesting, because you want those different perspectives. If we're not understanding not just the what, but the why and the how, then how are we going to address it? So yeah, it's kind of a challenge, but also definite strength if we can do it well.
Yeah, absolutely makes sense. I guess it's very difficult to balance the scientific rigor of being an academic or researcher with the messiness of real human experience and putting it into qualitative data. So let's say, as you're saying, that maybe acupuncture, for example, how would you, so yeah, if you've kind of got, with qualitative, somebody might have said 5 comments that nobody else has said, how do you then incorporate that into when your analysis or you're crafting your recommendations for what they should do?
I think with using the acupuncture example, it was trying to figure out why they thought that was important. So a lot of that came down to that kind of the main theme around choice. So it's that people wanted different options. They didn't just want this is what you get. They wanted a choice. They wanted to be able to choose what worked for them. So it was kind of unpicking that, the why rather than just the what. So yeah, so people came up with all sorts of different ideas, some of which were, completely impossible but lovely ideas, and some of which were just, a bit out there. So I wanted to kind of include all of those, and you don't want to dismiss people's ideas because they've come from somewhere. But it's trying to figure out why they think that's a good idea and what that might look like in a sort of slightly more generalised recommendation, but then without losing the individual voice. Tricky.
Yeah, absolutely makes sense. Why I honestly applaud anyone who works with qualitative data, because it can be really quite something, but really incredibly important.
I mean, we were only talking about the service user side. It would be on the other side as well, right? Of sort of the service providers. They'd all have opinions about what they can and want to do.
Yeah, there was definitely a divide between some of the staff who didn't think it was important, didn't think it was, they were very against the idea. And I suppose I was quite lucky that they even spoke to me, because a lot of people, when you say, I want to talk to you about smoking, people are like, it's not important, they don't care. So I was actually, those interviews were really important to understand why they didn't think it was important and kind of how that shapes what's happening. Interesting when you're going, this is my life's work and this is what I think, and they're going, no, we don't like that. So it's certainly challenging on a personal level, particularly because some of the interviewees were people that I had worked with. So which I hope was a positive, because they obviously felt comfortable telling me these things. But yeah, that's a slightly different issue. But there were definitely that sort of divide between the people that didn't think it was a good idea, usually because they didn't think it was in the best interest of people accessing services, not because they didn't care, but because they thought, we are here to stop somebody from, injecting heroin or whatever that may be, and that's our priority, and that's what we do, and that's what we do well. So the other stuff they felt was perhaps diluting some of that. So yeah, they were all very well intentioned. I don't think people work in this field. It's not because it's brilliantly paid or whatever. It's because people care about it. So that was sort of, again, unpicking that kind of why and what, if it was relevant, what you could do to kind of challenge some of those ideas.
I mean, you also mentioned earlier that people are competing for limited funding, so I don't think anybody's making a lot of money in this field generally. But that's an interesting point. So by thinking that they were diluting the service, was it because they would think that more people would come to the service if they were offering something, or they wouldn't have the capacity, or they have too many service users come, or is it just like focus wise that you're diluting what you can do?
Yeah, I think it was more focus wise, because a lot of people were dealing with not a crisis service, but they're dealing with people who are in immediate harm, in danger from what they're doing. Like, I spoke to one participant who was like, I've got people coming in, injecting heroin in their groin, this is going on. I'm not talking about smoking. I'm going to get them through the day, hopefully. So it's that kind of immediate priority. So yes, it was very much, I don't have capacity to do that as a member of staff, because I'm trying to keep people alive. I'm trying to deal with this thing that smoking might kill them, but it's not going to kill them today. So that's kind of how it was prioritized.
Makes sense, doesn't it?
Yeah, I mean, I do not envy people working in services that trying to deal with that kind of level of sort of firefighting and then trying to support people to have a long and meaningful life as well. It's a really difficult situation.
Yeah, absolutely. My sister works in the recovery services, and it's, you know, she loves her job, but she does it because she loves it, and it's yeah, it does sound quite something. So I think quite a lot of this, like what a lot of you're saying, like obviously the qualitative research, but a lot of it is having these interviews and this kind of like public engagement as well from both the service users and the people who are providing the services. So you contribute both to addiction audio and you volunteer with mental health charities. How do you feel these roles feed back into your academic work, and why are they so important, do you think?
I think I mean, it can be a challenge, but also a huge benefit. So for me, I think my lived experience and having that kind of connection with other people with lived experience is a really important influencing factor in my research. That's why I do what I do, and that's why I do it the way that I do it. But it can be really challenging of trying to remember which hat I have on. So particularly with the mental health and alcohol project that we're working on, you know, I had a group of people with lived experience, and I had not the same lived experience, but you know, the same type, if you like. So remembering I'm there as a researcher, not as a expert by experience or, you know, PPI member or whatever terminology you want to use. So that, I think, for me can be slightly difficult to separate the two because, you know, I'm not two different people. I have all these different, as we all do, all these different aspects. So trying to kind of balance that and remember which job I'm doing, because I do PPI work as an expert by experience or whatever, sort of with other groups. And yeah, I volunteer. I'm recently joined the board of trustees for Rethink Mental Illness. I've volunteered with them for some years now, and I really wanted to get more involved in kind of the organisational aspect of it and figure out, you know, how that can be shaped by lived experience. And as an organisation, they are amazing at lived experience involvement, co-production. They've been doing it for quite some time. Can't say it's always been easy. I've been involved in, you know, arguing and challenging some things over the years, but they keep doing it and they do it well. So that is quite sort of inspiring for me to think, well, they can get it right. You know, other people can too. So I feel like, you know, it's kind of a duty, if you like, to sort of push that agenda that it is really important and there's no reason people can't be engaging more with lived experience involvement.
Yeah, absolutely makes sense. And I guess from that, what was something that you'd wish that the public practitioners, policymakers understood more clearly about people with maybe even just substance use or co-occurring kind of substance use and mental health issues? So
I think
we try to drive home.
There's so much. I mean, things have changed a lot, but there's still stigma is still alive and well, unfortunately. There's a lot of perhaps outdated ideas about what someone with a mental health condition or someone with a substance use disorder looks like, and in some cases that they're somehow less deserving of treatment. Particularly with addiction, I think people are more inclined to blame someone for that. It's a choice; they picked up the drug or whatever. Whereas mental health has shifted a bit more, but we still have some quite outdated ideas. Like I say, I've been in situations as a person with lived experience, and the way I get treated in some circumstances can be quite frustrating, shall we say. Some of the things that you hear about, the assumptions made, is really challenging. And then I go, well, actually, I'm here as the researcher. You know, I've got a PhD, and the kind of perceptions are like, oh, and that challenges things. But yeah, I think generally speaking, we've got a long way to go in terms of challenging stigma.
Yeah, I still keep coming back to the thing which you said, that addiction services aren't treated the same way as mental health services are, when um yeah, well, with people, like we said, the comorbidity of the two is so high. I do not know the exact stats, but I remember reading somewhere that it's usually around 50%. If someone has a substance use disorder of some sort, they have 50% likely or slightly higher to have some sort of mental health condition along with them to some extent. With that, I know NHS are trying to pilot these things called mental health hubs. Have you heard about them? Do you know if they're viable? Have you spoken about them in any way?
It's something I'm aware of. I think still figuring out what that's going to look like is going to be interesting, because there's definitely the scope to do something quite meaningful. But with a lot of these things, there's, I think, perhaps a reluctance or a concern that it might be short lived. Certainly from the mental health sphere, we've seen a lot of changes over the last 10 years. And each idea is met with enthusiasm, and this is going to be the answer. And some of us, we get a bit jaded. We've been through this before. So I'm kind of cautiously optimistic, I think. And I think there's definitely scope to be introducing substance use into that. I think they should be, personally, I think they should be holistic and looking at the whole person, the mental and the physical health. Whether that happens or not is down to the people implementing them. But like I say, optimistic, but cautiously so.
It's like it's just sad about the stigma with addiction has just really got me thinking. It's of course we get older, we're going to have friends or your friends of friends who go on to become have substance use issues, and they're so embarrassed. Even if they're on the recovery, it's almost like I think I was chatting to a friend about this, and they said it feels like I'm the kind of the black dot in the family, I am the ink kind of spilling out, and it's sad, and I think we should be celebrating people who are have got through that, like one of the toughest things. So sad, but hopefully we can. One of the things, along with them empowering some of the service users and the service people themselves, and getting rid of that stigma.
Yeah, I think that is so important. And I mean, there's just so many different sort of levels of stigma that some of them are really well intentioned, but people can perhaps be sort of overprotective or shielding people from things because they're not sure you have capacity to deal with it. And so people generally, hopefully, mean well, but it's challenging. And I think even like in this conversation, the language we use is really difficult, particularly because it changes so often. Trying to keep it kind of appropriate and meaningful and authentic without over medicalizing it, because a lot of the sort of more traditional language around this sort of stuff can be quite stigmatizing. So I don't use the term alcoholic or addict because if someone wants to use that about themselves, that is entirely their call, but it's not something that I will put on people. Same with the, is it addiction? Is it dependence? Is it a substance use disorder? Is it, there's so many kind of nuances to it that it can be really tricky to even have an open conversation about it.
I don't know if you realize I'm stopping and pausing quite a bit to be like, I know that this is okay, and it's because you don't want to label anybody in something a way that's going to offend them, and it's I guess it's a constant kind of you're always bettering and finding out what you should and shouldn't be said.
I mean, for me, that's the most important bit. Language changes, people's use changes. As long as you're kind of not trying to offend anyone and you're willing to kind of adapt and try and learn from that, then I change what I say about myself quite regularly because it's evolving, so I think as long as we're open to that, then
language is a massive thing. I think, Zoe, we've seen in some of the PPI groups we've hosted together, that sort of the terminology comes up quite a bit of what's being said or how you say it makes a big difference. And that being willing to change, especially in sort of when we were talking about minority communities and the work we've been doing there, sort of the language being used, the statements being made, the understanding of these things can differ widely, and therefore you need to adjust and show that flexibility.
Yeah, definitely. It's really difficult because obviously everyone's got their own preferences. I say one of the term alcoholic can be really contentious because some people kind of feel that that's empowering to own it. Things like AA, that's what they do. I'm an alcoholic, and and I'm dealing with it, and that's something to be kind of celebrated. Whereas for other people, it's quite a stigmatizing term. So there's no right answer. I think it's just whatever someone wants to use about themselves.
It's giving people that empowerment that they can say they can live themselves whatever they want to be. This might be a good time to ask you about one common assumption or misconception about addiction. or mental health that you think deserves rethinking?
Big question. There's so many. I mean, in terms of smoking, if I'm going to be quite specific, one thing that I get a lot when I teach about this, it's people think that nicotine is the problem, that's what's going to kill them, and it's not. That's what makes it addictive. That's what makes you keep going back for more. But it's not what's going to be. That's why we use NRT. That's why we use patches, nicotine replacement therapy, patches and gums and all the rest of it, because you can have the nicotine without the really bad parts of the cigarette. So there's many debates around the use of e-cigarettes, but nicotine for me shouldn't be the focus of that. If someone needs the nicotine, then it is what it is. It's not likely to kill them.
Okay. I I think there's another question which we ask everybody, which I feel like we should. Beth usually asks it, but I'll ask it this time. So, this is looking towards the future. So, suppose you were given a grant of, let's say, £2 billion, or at whatever number, more money that you know what to do with, and I guess in theory the ethics boards are away. What would be your sort of dream research project, which you would want to do?
Okay, assuming that there's also no time limit on the project, what I
There is
would
no
love to
time limit on
do
the.
is a really long-term study on people accessing treatment for substance use. Because a lot of the studies we have, we're looking at 6-month outcomes, which is great and all, but it's like, what about 5 years? What about 10? This is a lifetime thing for a lot of people. So I would love to do something that embeds smoking cessation, not just into treatment, but into the recovery sector, and fund something like that, and then measure those outcomes over the whole course of somebody's life, and not just did you quit smoking. It's like, have your attitudes changed? Has your substance use changed? Has your quality of life changed? Has your mental health changed? And all of that stuff. So really in depth, and it would never get funded because the outcomes would be far too vague, and it would take years to get anywhere. But ideally, I'd love to do something like that.
The closest to that, which I've seen, is, like in the UK Biobank or any sort of longitudinal studies, sometimes they don't really measure the mental health outcomes to that extent, but they sort of see, like, are they still smoking or are they not, and you can pull that data out. I don't know if there's any other cohort studies which do it a bit better, but
There's
that's the
smoking
closest which I
toolkit
can think of.
study, which is really good. But I think for me, one of the key issues, which I probably should have mentioned earlier, is the outcomes that we're measuring. So I don't think a binary yes, no, have you quit smoking really captures that. Because, someone could have, reduced from 40 a day to, 1, let's say, and they'd still be counted as a, as a failure, if you like, as a smoker. You have failed at quitting. And that is why I think it's so damaging. Because we're kind of just undermining all that work that's gone into it. So I think we need to look at much broader outcomes and how those interact with other things, and also over long term, because you might not quit in the first 6 weeks, 6 months, but the idea is that you plant the seed then that someone might quit over a year, over 2 years. So I do think we need to look much more broadly at how smoking outcomes are measured.
Also, if you have unlimited funds, you can fund sort of the follow-ups being better, so that there's consistency in sort of check-ins and
Accessibility as well, exactly. I guess, as well.
Yes, you got to meet people where they're at. So if that means going to them, then great.
Creating an app, so it's on their phone to some people. You can do it in a multitude of ways.
There's so many ways, and giving people that choice again. But having the conversations, what do you think is important? If this is your recovery journey, for one of a slightly cheesy phrase, what does that mean to you? And what outcomes are going to capture that? Because, a simple, did you quit smoking? Have you used alcohol? Whatever it just reduces it down to something so small, and it should be so much bigger. And there are so many different facets of recovery that are really positive, and all kind of build up, hopefully, to a really positive recovery. But if we're not looking at all of that, then we're not seeing the whole picture.
Okay. So where do you see this field heading in the next maybe decade, both in research and in like practical service delivery?
I'm again cautiously optimistic with some of the work that's going on, that there is interest in expanding smoking cessation to include people in substance use treatment. I mean, ideally, we want to be expanding not just for people in treatment, but people who, for whatever reason, aren't in treatment, because there's a massive population that could probably benefit from treatment but aren't accessing it for whatever reason or aren't able to. So yeah, I think that's a really kind of key population that we're missing. So I'm hopeful that we will start shifting those norms around smoking, because for the general population, we've done really well. Smoking rates have reduced dramatically over the past couple of years, decades, whereas we're not seeing that the same in some of these subpopulations. So I think we need to look at that, all the different factors. So we know what works for smoking cessation, but how do we get it to these people that need it? How do we make it appropriate? So yeah, that's what I would like to see and what I hope we will see coming both in research and in practice.
We can get you back in 5 to 10 years' time to like get the verdict, whether it's been what you expected it to be or not.
Hopefully, hopefully it will all have gone wonderfully, but we'll see. I'm sure there'll be some new challenge we haven't thought of by then.
And what about yourself personally? We spoke about your PhD and then your current sort of work. What are you planning on doing in the next 5 to 10 years? What's your next research?
I've got a lot of ideas about what I'd like to do. I think in terms of methodology, then anything PPI related is really important, and that's probably to some extent more important than the actual content for me. It's really shifting those ideas and hierarchies within research and within practice. So it's not just, we don't just have a sort of token person with lived experience. We actually embed that, so that should be across the entire life cycle of a project. How we come up with the idea in the first place, how we see if it's worth doing. So that's the work I'd really like to be doing, preferably in the kind of substance use, mental health, and recovery kind of field, and say smoking being part of that. But yeah, that's the really important bit to me, is getting that lived experience firmly embedded, which we've changed a lot over the past few years with that. It's great to see it being recognised a lot more, and so many funders expect it now that we kind of have to include it to some extent, but making sure that it's really meaningful and not just a kind of, the funders want it, so we'll tick a box, but how to really use that to its full benefit, for the research and for the people taking part and for the researchers, and then hopefully the impact of that. So yeah, I could bang on about this all day, but it's a win-win if it's done well. Everyone benefits.
Yeah, that sounds really important. Is there any kind of research that you particularly want to share, or any questions that you feel you want to talk about?
Which we haven't covered?
I think we've covered quite a lot of the stuff that I had on my notes of things to mention. I say that, yeah, I can recap, but yeah, the lived experience bit, always going to be important. I'm really interested in those outcome measures and how we can improve them. That's kind of, I think, an under-researched area. This is where someone tells me they've already done it, but looking at how we can get a consensus from people in treatment, whatever that treatment may be, and kind of working with then the people who process all that data, and from the government and all the rest of it, to balance that so that an outcome isn't just yes, no, did they quit at 6 weeks? It's, how do we make that something that's meaningful and useful across the board? And yeah, that's most of my PhD, although it was obviously on smoking, was sort of about challenging the research hierarchy and how these things happen because they've always happened, and sort of challenging some of that. Maybe an RCT isn't the best way to do this, which some people will probably think is hugely controversial, but it's about kind of challenging the whole mechanisms of research and making sure that that's fit for purpose and really empowers people and produces useful and meaningful research.
And one final thing, Zoe, what is your hot take?
So I think that a reduction in cigarettes smoked should be included in every smoking cessation intervention as an outcome.
Mm-hmm.
And that might not sound particularly out there, and there's a lot of controversy around this in smoking cessation research, and I think it's really important.
Okay. What's the controversy?
There's sort of limited evidence that reducing the number of cigarettes you smoke actually have health improvement outcomes. So there's kind of well, what's the point? If you're still smoking, then you're still going to get cardiovascular disease or whatever. But for me, it's not just about cutting down and that being the outcome. It's about the bigger picture. So encouraging someone to cut down and supporting that and celebrating that is more likely to lead to them quitting or making other positive changes. It's encouraging people and making them feel valued and that their choices are are worth doing. So for me, it's about that kind of bigger picture, which is not necessarily going to be as useful for definitively measuring smoking cessation. But I think if we're talking bigger picture and longer term, then that kind of harm reduction approach, whatever that may be, should really be included as a valid outcome, and it's not in a lot of studies.
Awesome. Oh, thank you.
That's really interesting.
That was awesome. All right. So thank you so much, Zoe, for coming on.
Great.
Thanks for having me. It's been a pleasure.
And thank you, everybody, for listening. And until next time, take care.
Bye.
Bye.